As we begin our discussion of Class II inlays, we again consider the permanence of gold castings and why they last, because this is the greatest attribute by far of this type restoration. I speak often of a friend, Dr. George Elsterman, who has been such a great influence on me and many others as a teacher of gold foil and castings. These castings were made by him 43 years ago, and you can see from this picture why I refer to the effect of bracing the enamel when referring to lack of breakdown of margins, when the gold is closely adapted to the tooth margins. These castings were made with type 1 gold, with a hardness of probably 75, so the surface is pocked and the finish is not as it was when the inlays were placed. But the integrity of the margins is remarkable. Why do gold castings last? Excellent margins can be produced that do not break down after years of service. Coefficient of expansion is similar to enamel. Occlusal wear is similar to enamel. Gold does not tarnish or corrode. And well-fitting castings support that remaining tooth structure. Whereas these cavities could have been filled with other types of materials, the greater value of the gold castings in regard to permanence, tissue health, and patient comfort cannot be contested. Even from the aesthetic viewpoint, these restorations should not create tooth discoloration, and we have developed several concepts in the preparation and design of cavities to allow little or no display of gold. As we view these inlays, I call your attention to the contours and dental anatomy. Notice the contact is at the buccal third of the tooth. Dr. Gerald Stibbs has referred to this as the ears of the tooth, with the lingual embrasures open so the food can sluice off to the lingual. To avoid a point contact, which is not desirable, of course, the contact is on the vertical plane, so as the floss passes through, it does not snap between the teeth, but is in contact with the adjacent tooth for perhaps 2 or 3 millimeters. We also try to reproduce rounded, fully contoured marginal ridges that slope off to the lingual. Let us now proceed to the clinical case. As we go through these procedures, you might note that we follow these steps in the cavity preparation, which are quite standard. The advantage of following the steps in order are that it saves time and effort in avoiding recutting, and if each step is done well, then the final result should be good. These are the steps that we would use. First, the rubber dam is placed. Then we remove the old restoration and caries. Place the calcium hydroxide base. Place the composite buildup in the cavity. Do the occlusal preparation. Then the box form. Proceed with the instrumentation. And finally, the occlusal bevel is placed and the walls are disked at the proximal of the cavity. We're going to demonstrate today a Class I and Class II inlay. Debbie Avery is our patient, and this is my assistant, Pam Lavers, who has been with me for many years and is a very competent assistant. So we'll proceed with this operation. These are rather typical indications for inlay castings. The second molar, as you see, has an old composite which is eroded and under-contoured now as it is washed out. So the maxillary tooth has erupted into that tooth, and we'll want to build the inlay back up to normal contour. The MO amalgam on the first molar will be a typical replacement with a gold casting. We always like to use the rubber dam for this procedure because it retracts the tissues away from the tooth, the interdental tissue, so that we don't injure the tissues, and also so that we can see the gingival margins and to place the fine bevels on the margins and instrument the tooth properly. We first remove all old restoration and caries to allow us to observe the strength of the remaining tooth structure. And at this time we can determine the outline and design of the cavities, whether cusps should be protected, and if a supplementary retention will be needed. This is followed by applying a thin layer of die-cal over the entire cavity, which serves a double purpose. First, it protects the tooth from the toxicity of the composite we will use as a base or buildup, and it acts as a separator for easy removal of the composite when we remove it at the time of cementation of the castings. When the die-cal is set, which we sometimes need to speed up by a little water spray, we then press an ample amount of chemical cure composite into the cavity to serve as a buildup. This is an important step as it allows us to prepare each wall of the cavity to an ideal depth. It is seldom that we can place an inlay in a tooth with such a small lesion that a buildup is unnecessary. The composite buildup is an intricate part of our preparation because it helps us so much to keep the outline restricted. You can see from this diagram how much less extended the cavity is when the pulpal wall is set to an ideal depth. And of course the same applies to the proximal extension when the axial wall is kept to ideal depth. This series of pictures will demonstrate this also. You can see the extent of the lesions when the old alloy and caries is removed. The calcium hydroxide paste is applied to protect the dentin and pulp from toxicity of the buildup material. The composite has been placed and the preparations are made to ideal depth and the extensions are kept minimal. The dies of the prepared teeth show the rather ideal pulpal wall depth and the axial wall depth, which helps to restrict the outline. Of course, if the gingival wall is kept short, it allows a more conservative cavity design also. When the patient returns, the temporaries are removed. The rubber dam is placed and the composite buildups are removed, cavity varnish applied over the dentin, and zinc phosphate cement is flowed into each cavity as each inlay is placed. The outlines have been restricted nearly as much as the old restorations. This is as the picture is enlarged, showing again the restricted outlines allowed by this technique. So we will now prepare the cavity as ideally as possible. The pulpal wall is established to ideal depth using a 57 burr for molars and a 56 for premolars. Then the occlusal outline is placed so the pulpal wall is smooth and the walls flare evenly. As we prepare the cavity with this 57 burr and we're placing the outline, if we can tilt the burr a little distally as we approach the distal aspect of the tooth, then turning it to the buccal, and as we approach the buccal fissure, we then lift the burr a little so that the wall will draw mesial distally, and then we drop the burr a little as we approach the mesial buccal cusp, and again tilt it buccally as we go around the cusp. So we move the burr both mesial distally and buccolingually, not just buccolingual as you might expect.